The next presentation is virtual. Role of growth factors in smooth muscle cell migration in tissue-engineered vascular grafts, presented by Dr. Wes Livingston from Wake Forest.
Hi, my name is Lauren West Livingston. I'm an MD PhD student at the Wake Forest School of Medicine, and I'm here to talk about the role of growth factors in smooth muscle cell migration in tissue-engineered vascular grafts. Neither myself nor my co-authors have any disclosures. Peripheral vascular disease and vascular trauma are what we hope to address with this research. Over 200 million people are affected globally by vascular disease, and vascular trauma includes penetrating wounds, blunt trauma, a combination of the two, or iatrogenic trauma from invasive medical procedures. Bypass and interposition grafting are ways to address, or one of the many ways to address vascular trauma and peripheral vascular disease. There are commonly used conduits such as autologous vessels like saphenous vein, which is the gold standard in vascular surgery, or synthetic grafts like Dacron and polytetrafluoroethylene. Autologous vessels have pros and cons. Pros include no immunogenicity. Superficial vessels are often easy to harvest and have good dimensions for site matching. However, each patient has a finite supply of autologous vessels, and extensive vascular disease or trauma may prevent us from using those for bypass or reconstruction. Synthetic grafts come in many different dimensions and are available off the shelf. However, they have compromised patency over a shorter period of time compared to autologous vessels. This graph is from an unpublished manuscript from our lab. It basically just shows the black lines represent procedures performed with saphenous vein. The blue lines represent the exact same procedures performed with polytetrafluoroethylene. And you can see that in every case for similar procedures, the use of PTFE causes a loss of patency much sooner than the use of saphenous vein for the same procedure. This is often attributed to increased thrombogenicity and intimal hyperplasia, especially in smaller diameter grafts. Tissue-engineered vascular grafts can be a solution to this. It utilizes the patient's autologous cells, and for small diameter grafts, endothelial cells and smooth muscle cells are crucial to the success. There are many limitations, including the quality of patient biopsy, limited size and shape of the native scaffold. These can take a very long time to fabricate, which most patients don't have, and newer modalities are associated with higher costs. The objectives for this study, overall, we're building a scaffold that can be electrospun from polycaprolactone and collagen. Antithrombotic agents such as heparin can be used to prevent clots. Dual factor endothelial cell capture can help capture circulating endothelial cells to the luminal surface. Growth factors can be used to induce smooth muscle cell migration from the native tissue into the outer layer of the scaffold. And anti-proliferative drug loading can be used with our polymers that can be released over time to prevent migration of the incorrect cell type. We looked at the literature and saw that platelet-derived growth factor with 2 beta subunits and stromal-derived factor 1 alpha have been successful in recruiting vascular smooth muscle cells and causing proliferation on electrospun grafts. And basically, these are some of the conditions we used for our study, but we exposed our scaffolds to these agents and allowed for covalent ionic chemistry to allow the factors to bind to our grafts. We looked at each condition over 4 weeks. Notably, the conditions of 100 nanograms of PDGF and 500 nanograms of SCF were what was in the published literature. We tried a couple different concentrations to see if varying the concentration affected the outcomes in any way. First, we characterized the scaffold, making sure that by adding these agents, we were not modifying the structure of the scaffold in any way. We saw that pre-exposure and post-exposure to these agents, there was no difference in the morphology of our fibers. For the single factor study, we looked at each week and we used DAPI staining to see the proliferation of vascular smooth muscle cells on the surface of the scaffold, and we quantified that over time. This is an example of what that looked like in week 3 for the single factor study. And when we looked at the results over 4 weeks, we saw that the best 2 conditions of each agent were actually exactly what was in the previously published studies, which was encouraging, meaning that our experimental design was sound and that their studies were replicable. We then combined these to see if dual factor caused any synergy in the ability to recruit smooth muscle cells or proliferate them on the surface of our scaffolds. What we found, we did basically the exact same design as the single factor study, and what we found over time was that while individual factors cause more proliferation than the unmodified control, the dual factor allowed the cells to migrate deeper into the thickness of the scaffold. So we looked at this in terms of quartiles and how far each scaffold allowed the cells to migrate. We saw that the dual factor, which is all the way on the right, condition 3 in these graphs, the blue line represents 25% migration, the orange line 50% migration, the green line 75% migration, the yellow line full thickness migration through the full scaffold. You can see that in condition 3, the dual factor, there was a more even distribution of cells throughout the entire thickness of the scaffold, which was encouraging for the goal of using this in patient use. So our conclusions are that using a single factor caused more proliferation than an unmodified control. However, using a dual factor cause more proliferation than an unmodified control, but more migration to the scaffold thickness than single factor conjugation. And these are both in the in vitro setting. Limitations, we didn't use heparin conjugation like previous studies just because this was a proof of concept. And when we replicated the results from previous studies, we felt like that was sufficient. We also did not quantify the extent of passive absorption of these growth factors onto the scaffold. Future directions include looking at these growth factors along with heparin and other surface modifications like the dual platelet or the dual antibody for endothelial cell attraction. We also want to look at cytotoxicity to see if using two agents together or at different concentrations causes cell death, and that may be why we didn't see as much proliferation with the dual factor, though we saw more migration. And of course, we're currently moving towards in vivo studies. These are my references. I'm funded by the Armed Forces Institute for Regenerative Medicine. I thank them for their funding, though their opinions, interpretations, conclusions may be different from mine. I don't represent the Department of Defense. I also like to thank animal subjects for their sacrifice, my PI, Dr. Sangjin Lee, and the Lee Lab, everyone at the Wake Forest Institute of Regenerative Medicine, my dissertation committee, and the Department of Vascular and Endovascular Surgery at Wake Forest who've been so supportive. And of course, I'd like to thank my friends and family, especially my better half, Dr. Donovan Livingston and my daughter, Joy. And now I'll take questions. Thank you so much for your time, and I really appreciate it.
Paper's open for floor discussion.
Hi, Jeannie Reddy from Medical University of South Carolina. Nice to see you, Lauren. This is great work, and thank you for presenting this today. And I just wanted to ask if you could recap a little bit of where you guys are with your testing for endothelial cell adherence, since that's also a big part of promoting patency. And then how can you integrate the factors that you need for smooth muscle cell integration and endothelial cell adherence going forward to really optimize your scaffold?
Yeah, thank you for the question. It's wonderful to hear from you. I can't see anyone, but one of the plans that we have is to do a bioreactor study in order to test all of these factors together in the in vitro setting. We've also been approved for rat studies in the in vivo setting. That was a little bit derailed by COVID, but we do look forward to combining our different modifications, like I mentioned, heparin conjugation, dual antibody conjugation, dual factor conjugation, muscle cell growth factors, all in one scaffold, and also with the anti-proliferative drug fiber loading. So we want to try all of those together and in different combinations of all of those. And the actual goal is to see how good of results we can get with as few modifications as possible. So we're trying to see what's the least we can do to get the best results, but we do want to see if there's any interaction.
Misty Humphreys from UC Davis. I was interested in why you have to put heparin into these grafts. Is the scaffolding itself highly thrombogenic? And if you were able to get endothelialization, do you think that you would need heparin to prevent thrombosis, or is it to potentially increase the longevity of patency of these grafts?
Yeah, that is a great question. So our scaffold design, different scaffolds are made from different materials. We use polycaprolactone, which is synthetic, and collagen, which is natural. And since collagen is prothrombotic, we use the heparin just in case. Also, we're working with scaffolds that are under 5 millimeters. In our rat study, they're about 1 millimeter in diameter, so very, very small. So the heparin is to make sure that there's no clotting prior to endothelial cell deposition. If we can get great endothelial cell deposition, eventually the scaffold itself will break down and leave just the cells behind. So that is the goal, but it is to immediately prevent thrombosis.
Thanks. Congratulations on your incredible early scientific success. We look forward to seeing you at this meeting for many years to come.
Thank you.